Okay, good morning, everyone. We are on our medical minutes, the moment to share acknowledgement about infrared imaging, thermography, and anything that is related with thermology. I'm here as a chairman of American Academy of Thermology, and today we will have a pleasure to have a speaker. She is a specialist on infrared imaging. She's doing infrared imaging, I think, more than 8 years, Cidalia.
Yes. Yeah.
Years. And she has a very large experience on clinical approach and also on this topic that she will explain. Cidalia Awadi is a medical doctor.
They can't hear me if I have that.
Works with acupuncture also.
I'm muted, right?
Metal
Yeah.
too. So she will talking about the first slide, Cidalia, please.
Okay.
She will talking
Just a moment, please.
about how can infrared imaging predict cardiovascular risk events in our daily medical practice. This is a new topic for the most of people that works with infrared image, but for the new ones, it's something that most of them are learning during their training. So, thanks so much, Cidalia. Welcome to our medical minutes, and you can start our discussion. You have 15, 20 minutes to present your case. And after this, I will want to discuss with everybody here, making your questions and suggestions, comments. So enjoy, everybody. Thanks so much, Cidalia.
Thank you, Professor Brioski, for this opportunity. Thank you, everyone, for being here. I'm very happy because I've just become American Academy of Thermology member this month. So thank you very much, everyone, for the support. Okay, so how can infrared imaging predict cardiovascular risk events in our daily medical practice? It's a case report that will represent very well this subject. The blue here goes for the men's health because I want to say to every man, you are really important to our lives. So be careful of your health, and we are in the blue November, okay? Let's go to the first slide. Why did I choose this theme to bring to you here? Because cardiovascular disease, or CVDs, are the leading cause of death globally. And let's see what the World Health Organization says about it. It says that an estimated 17.9 million people died from CVDs in 2019. And 32% of these represents all global deaths. 85% were due to heart attack and stroke. So it's very important for us to understand this point. It also has a very high, it comes alone by itself. It has a high cost to society and government. There is also a significant medical cost for the treatment, for the rehabilitation, and also loss for the family. Imagine how many people need to leave their jobs and to have a financial problem because of these disabilities, okay? So that's why it's so important for us to detect cardiovascular disease as early as possible, so that management with counseling and medicines can be our main point to prevent this disease. What are the main risk factors for cardiovascular disease? Wait a minute, why is it's here? Sorry, I have to adjust something here. I don't know why it came another point here. It's not here at all. So, okay, it's fine now. Maybe. Can you see my full screen?
Yes, we do.
Sorry, something happened that now I can't. Oh, okay, I found it. It happens. Hypertension, high cholesterol level, smoking, obesity, physical inactivity, diabetes, family history, stress, also depression, social isolation, everything are the main risk factors. And when we talk about cardiovascular disease, we're talking about vascular endothelium. And it depends the integrity of the neurovegetative nerve system to function quite well. When it doesn't happen, when the system, neurovegetative nerve system is imbalanced, we will lose the nitric oxide production, the maintenance of the smooth muscle relaxation, the blood pressure control, and antiplatelet aggregation. So this dependent is very important, but it's not also depend on the production of nitric oxide production, but the endothelium vascular also deals with endothelin 1, also another factors and bradykinin and other factors that influences his autonomy, his function. We are going to see this later, okay? Now we are going to tell about the systemic microcirculation dysfunction, because it's not only about heart attacks, not only about stroke. We're talking about the systemic microcirculation dysfunction when we deal with endothelial dysfunction. And it means that it's not only coronary disease, not only cerebrovascular disease. It can happen the preeclampsia and thrombosis during pregnancy, also erectile dysfunction, and so on. It's really a systematic microcirculation dysfunction. Now let's present you our patient. He's a 61 years old man, Caucasian, recent divorce. He's a carpenter, normal weight, controlled hypertension, pre-diabetic on metformin. He has insomnia, high stress level because he's very anxious, and alcohol use. It's not alcohol abuse, but also not like a social use, a little bit more. So I decided to put alcohol use, okay? His complaints, about his complaints, when he came for the consult, on the day of his consultation, he complained of numbness sensation. Oh dear, it's going by itself. I don't know why, sorry. By numbness sensation in the left arm, the transient dizziness and loss of memory. Also, he felt himself very lonely. He had just divorced. So he wait a minute, please. Okay, so he has this complaint, and he has some of that risk factors too that we're going to see after this slide, okay? In his exams, he brought the carotid Doppler, and he brought some exercise stress test and CT angiography. The carotid Doppler had no plaquettes, okay, no stenosis. It was quite normal, but it has a bilateral thickening in the intima media complex. The exercise stress showed that there was no sign of exercise-induced myocardial ischemia. However, at the CT angiography, it revealed a non-calcified plaque in the left anterior descendant artery with a slight luminal reduction of less than 4%. That is not so important, okay? But there was a diffuse mixed plaque in the right coronary artery. However, there was no luminal reduction, and it was seen by his doctor as a mild or very low risk factor for him to develop any cardiovascular disease. He recommended a balanced diet, a physical activity, consult with an endocrinologist, maintain metformin, aspirin, and rosuvastatin. This consult happened about 5 months ago. However, this patient was very worried about this because he felt dizzy most of the time. He was having trouble with his sleeping, and he commented this with his friend. His friend knew my work and said to him to make an appointment with me. And that's why we're going to talk now about how I dealt with this problem, with this patient. I use the thermoendothelial test. I don't know if any one of you have heard about this. The thermoendothelial test is it's a non-invasive test because it's an infrared image, as everybody knows here, and very easy to make in your own office. You don't need to send the patient to a hospital. The patient doesn't need special preparation, not more than we do for thermography, okay? And given this clinical scenario and his exam's result, I decided to evaluate his cardiovascular risk using this infrared imaging that it's called a provocative test. It's called the thermoendothelial test. Let's see, what is it? It's in endothelial provocative function test by thermography marker. And also, it's an additive prognostic value. It also improves risk stratification in health low-risk individuals. And in 2011, in Circulation, Dr. Anderson published that this test had higher results than the Framingham and PCR scores that we all know about, okay? So this publication was very important when validating this method. What does the thermoendothelial test measure? It measures the rebound temperature. It measures the neurovascular reactivity index. It measures the total vascular reactive index also. And what does it mean? It means that this rebound temperature is, oh dear, sorry. Things are not easy for me here, not today. Sorry. It provokes a reactive hyperemia of the hands induced by flow-mediated dilation of the brachial artery. I think all of you have heard about this test made with ultrasound to measure the reactivity, the sympathetic response by inducing a flow-mediated dilation of brachial artery. But it's different from the thermoendothelial test because we are going to see in the next slide. About the neurovascular reactive index, the normal value must be more than 1% of 1 centigrades, okay? And what does it mean? It shows the sympathetic nervous system activity. When the result is below 1 centigrade, it indicates sympathetic vasomotor hyperactivity. And the total vascular reactivity index, it must be more than 10%. Here is not centigrade, it's 10%. And when it's low, it shows that there is a reduction of endothelin-1 and nitric oxide production. So we have a greater vasoconstriction in this case. Now imagine all that risk factors and these bad results in these exams. We can predict the outcome for this patient and the risk for his cardiovascular disease. To do this thermoendothelial test, we have to prepare the patient, but it's a very easy preparation, not different from the one we use for our thermography. So we have a room thermalized in 23 centigrades. Also, the patient must be there for 15 minutes. The position of the patient's hand is, he has to be sitting with the arm comfortably on the table. I use this EVA pad, so that my table is a glass table. It could be colder, and it's change the temperature with the hand of the patient. So I use this EVA pad. It's better to preserve the temperature of the hands. Also, you need a thermal image camera that we put on the tripod, so you don't have to hang this for 12 minutes, because all these tests takes 12 minutes. And in front of the patient, point that the hands rest on the table. You need a sphygmomanometer that usually we put on the right arm, and you must compress the brachial artery to its maximum. But now we are going to see the steps or the protocol for capturing these images. First, we must obtain 2 initial thermal images of thermalized and resting hands, 1 minute interval. So this first image here and the second image here must be taken without the brachial compression. Then you quickly suprasystolic compression at 200 milligrams of mercury for 5 minutes. And during these 5 minutes, you are going to take or capture 1 picture at 1 minute. So it will be 1, 2, 3, 4, 5 pictures with a brachial compression. Then you release very quickly the cuff. And when you release the cuff, you take another 5 images with 1 minute interval. The total will be 12 thermal images. After this, we download these images to this software, and the software will analyze the results. And here is the exam of this patient that was done on November 60, okay? Not November 6, sorry, June 11. I put in American style here. So June 11th, 2024, when he came to my office. And here we can see the results. His total vascular reactivity was minus 1.32 centigrades, and the ideal is more than 1 centigrade. Imagine that he has problem here. The neurovascular reactive index also was minus 1.13, should be more than 1 centigrade. And the rebound temperature, I changed here, is the total vascular reactivity, should be more than 10%, was 3.96%. And the rebound was less 1.32 centigrades. Oh, what we see here, he didn't reach the reference and nor the ideal measures. So the result must be something not very good for him. Let's see what happened. This is the graph showing the right and the left hand. This is the right hand, the one that had the compression of the brachial artery, and this is the left hand. What we can expect here, if he had the health endothelium with a very good function, we would expect to have here a different graph. What should be? for example, in these first 2 minutes, we have both hands without compression. So they have almost the same temperature. When you compress the brachial artery, this reflex, the sympathetic reflex, would down the temperature of this hand. Okay, it happened here, but not so in a normal way. But also, we expected the reflex of vasodilation in the other hand, the contralateral hand. It happened, but so little. That's why the numbers that we saw here were so poor, not reaching the ideal pattern that we would like to have. And it, after this compressing, after releasing the cuff, didn't change much, okay? We should expect the right hand to warm more and the left hand to go a little bit warmer too. So it didn't happen. And what was the result? The result was badly, the worst. He was, when I saw this result, I said, my gosh, what am I going to tell him now? I have to do something for him. And they start a prescription, and also I recommend him to look for his cardiologist, so we could follow up his treatment. And I made some comments and orientation, but I thought, what should be the next steps when we are face to face when one of these cases in our daily practice? We must move on. Take advantage of this therapeutic window. We can't lose this gold time. Otherwise, this patient may have a stroke or cardiac arrest or something like that. And what happened? Happened that he lost the gold time. He went to the doctor, and the doctor didn't know this exam. He didn't give the right value for these results. And I reported this result to him, and I asked him to investigate more invasively this patient. But he said to him, no, don't worry, it's nothing. Your angiotoma is okay. You have only non-calcified plaque that does not obstruct it more than 40%. So that's okay. Just live your life, take your medicines, and do some exercise. Wow, when it happened in October 23rd, 1 week behind, he had a heart attack. He went to the emergency room. There, they sent him to the hemodynamics, and he went through a catheterism. And the catheterism showed that the anterior descent coronary artery was 80% obstructed. Here before the stent, here after the stent. He also had another obstruction in the right coronary artery with 9% obstructed. That was the cause of his pain and his dizziness. Here's before. Can you see my point?
Yes.
My pointer? Yes, okay. And here's after, okay, they stent. So this patient deal quite well with this treatment, and he had his medicines adjust. He's now on ticagrelor, aspirin, rosuvastatin, pantoprazole, losartan, metoprolol. I don't know this name in English, sorry, but he's very, I think he's well conducted. And when he came back to my office last week, I said, okay, let's move on. Let's do your follow-up. It was November 1st, the 1st, and I had here the image of the BTT. BTT is the brain thermotunnel. And I found this discrepancy here. I found that the delta between the right and left BTT are more than 0.4. it's 0.55, 55. It shows us that something is happening here in the circulation, maybe an obstruction or plaque in his internal carotid. We are going to investigate more. Also, I made here how's the name? A formula to see his noradrenergic hyperactivity, and we do this by taking the maximum temperature of the BTT minus the less temperature of the nose, and we got 5.53. It means that now, with all the lifestyle changing that he's done, he decreased this noradrenergic hyperactivity, because before he was more than 10. I didn't bring here because I didn't want to spend a lot of time talking about this, but I'm telling you, and believe me, it was more than 10. And now he's getting better of his anxiety. Okay, and I brought this interesting imaging that was I was very, very happy to cut this imaging, because we all know that about the visceral cutaneous reflex that happen when a person has cardiovascular arrest, cardiac attack, a cardiac arrest, a myocardial infarction. And this is the pattern of the visceral cutaneous reflex of the sympathetic nervous system for the myocardial infarction. You have this high hyperintensity zone on the chest area, on the left chest. And despite of being 1 week after the heart attack, we can still see this asymmetry here. I imagine that in the day, during the day, or the moment he was having the pain, it should be bigger, as Professor Brioski showed in another time in one of our classes. Maybe he has this image and can show later, because he had he captured this image at the moment of the heart attack. But here is 1 week after, and after also the stent, after the new medication and change of lifestyle, but it's still here. So I asked him to come back to my office each week, every week, for the follow-up. And I'm very curious to know how much time does it take to become a normal pattern, okay? So I brought here for you because I found very interesting. I found that it can be seen by you, and maybe it will be the first sign that something is wrong with your patient. I remember that about 3 or 4 years ago, when I was with a little camera, I was with a C5, I didn't have this professional camera yet. I had a patient with complained that pain in his left shoulder. And when I took the image, I saw this image. I didn't know yet what it was. And I asked Professor Brioski. He said, oh, it should be something in his heart. And you must send him for a cardiologist or something like that. And I did. And he went to the catheterism, and he had 3 stents. Imagine, it was just, how you can say, in Portuguese, we say achado. It means something that you just see. You are not looking for it, it appears for you, okay? So be aware about these patterns, these imaging patterns. The next one, we are just finishing. And now I became very, last Friday, on November the 1st, I repeated the exam, and he came from the very high risk to the moderate risk. Yeah, that some change is happening after the obstruction and after the new medication, change of lifestyle, etc. Because one thing that we must be aware is that the endothelial function can be repaired if we take the right conduction, the right treatment. If the patient is compromised with his life's change, and he said he left the alcohol, he's not eating a lot of carbohydrates, he's not eating glucose and things like that. So I'm very happy with this result because he's improving, right? And that's to say that the thermoendothelial test is very good for the therapeutic follow-up. We can have regular reviews of this patient and see if the therapeutic is all right, if we can improve the therapeutic, change some medicines, and do something else for him. And also the patient, when he sees the result, he became more compromised. He said, oh dear, if I don't do anything, I will die, okay? So it's a very good opportunity to show the result to the patient. And what I want to leave for you as a message is, it is always possible to make a difference in anyone's life when we truly care. Infrared technology breaking the barriers of old paradigms. Thank you very much, everyone, to be here supporting my speech, my presentation. I hope everyone has enjoyed, and now we're going to open the floor for your comments and so on. Thank you very much.
Thanks so much, Cidalia. Congratulations. Your presentation is such an impressive clinical case, and this was a severe cardiac case, and you are able to identify the high risk before the patient had a heart attack. Unfortunately, we see how it's difficult when you identify, and most of the time the patient doesn't understand so well or don't follow everything we explain. Unfortunately, it seems the patient did not follow your advice, and I would like that you explain about that. And eventually, he suffered an infarction, stroke, and it's truly a pity that he didn't take your guidance early. However, the follow-up with precordial thermal imaging and has confirmed that vascular disease is still present, is it? And he needs to take care of himself. What your comment about Cidalia?
Yes, the first thing that I'm very aware now is the necessity to show to our colleagues that this exam exists, it's easy, it's cheap, it's very quickly, and it's very, very sensitive and has a very good specificity. And also it was validated that the result can be better than Framingham and PCR scores. And there is another particular thing that I would like to stress here. Usually, when you have a TC or CT angiography, that it says that the calcium score is low, I mean, it's high, sorry, it's high, and says, oh, don't you worry, you have a high calcium score, no problem. You are not going to have a stroke, you don't have ateromatosis, things like that. It's not the truth. Why? Because some studies shows that the non-calcified plaque is the danger one. It's the one that when you the pressure of the inside of the vase goes over the stable pressure, it dislocates the plaque, and this plaque will obstruct an artery. And I believe that was what happened to him, because the CT angiography 2 months before had only 40% obstruction, and the plaque was not calcified. And he said to me that was on a divorce period, was very anxious, had a high blood pressure and things like that. So it all contributed for this amount of pressure inside the veins and dislocate this blood clot. Okay, so be aware about this, and always, I believe now every day, I believe more in the infrared imaging. When I'm looking for something and infrared image doesn't show me, I stop everything and start to think, what is happening? Where is the cause? Maybe the point where I'm looking for is not the cause, is the consequence. Where is the cause? Okay.
The endothelial test is fantastic, is easy, is quick, and is straightforward for anyone with a thermosensor and that do the right technique. But it's not enough just to perform the test, as you showed. Interpreting the results is very important, to know how to interpret this and how to provide the patient, especially with a strong guidance, is crucial if there is any risk, because it's not just only do, you must to explain the patient, you must follow the patient. It's not only one test. You can, most of the time we do 4-6 times a year these exams, so it's totally different from the breast. Breast, most of the time you do once a year or maybe 2, depends. But in this situation, you do much more the monitoring with endothelial tests, because the changes are very fast here and could be prevented. For instance, if you change the nutritional support, you give supplements to the patients, or you start some specific drug when it's necessary, you can change totally the result in 1 month or 3 weeks. So this test is very good because you can follow up very close the endothelial function. Endothelial function is very related, is very closely related with cardiovascular events. Not only heart attacks, but strokes, brain strokes, diabetes complication, and other neurological diseases are studying this as Parkinson, Alzheimer, and erectile dysfunction, and pulmonary hypertension. So there are many other diseases, and also eclampsia in pregnant women. So there are other diseases that are related with this test. This test is not specific to diagnose a specific disease, but it shows is a biomarker for many important diseases. And Karin is here. I saw her name. Karin, are there? Please open your audio. I would love to hear from Karin in Boston.
Yep, I'm here.
Oh, great. Good morning.
Good morning. I can't get my video to work, but at least the audio is working.
No, okay, could be the audio. Please tell us, share with us how the endothelial test training went when I taught it to you in Boston. And because you was one of the first ones to be trained by me at US. And tell us about the training, if it was easy or not easy, and
Well, it was very easy, right? So, and it was wonderful, obviously, to meet you, and to work with you. So the training, I think once, the protocols we have down in writing, I think it's going to be easy to do. And, we just have to follow the right protocols and do the cuff the right way, and, put whatever on the images correctly. But I have actually clients that are waiting to do it. So whenever you're ready.
We had experience with 3 or 4 cases.
Yes.
And how was how the patient received that? What was the reception about the results? What they told to you when they saw the results, and what do you do after these, Karen?
Yeah, so I work with them on, obviously, I'm also a health coach and I do a lot of other different services. So I've worked with a few of them on their diet, exercise. Some were already on programs and knew that they had some cardiovascular risk. And so what we're doing is, that's what they're ready for, is monitoring and going forward to see, okay, have their, cases been improved? So and right now, so there really hasn't been much since that time that we met. So, obviously Dr. Kane and I have talked about hopefully, getting this going soon.
Yes, I would like to thank you, Dr. Kane, to help you on this process. And wait, Karen, we will go to the second step in the next moment. And everybody is learning. It's a curve of learning, and you started this very well. And it's most important here that we understand, and the case of Cidalia, because Cidalia showed a patient that she previewed the stroke. So she previewed the stroke of that patient. And so this test is very sensitive. If the patient had another exams, but it's totally different when you have a functional exams as infrared imaging, and you measure the perfusion on the hands, and that give you a reply, or how is the function of endothelium. So it's very important, it's very sensitive. And in my opinion, it's so important as the breast exam in another point of view, but it's very important that we learn about that, start to do these exams with our patients, and especially find new solutions to solve this problem. It's not only the drugs, and we know it's very difficult to say to the patient, go to the gym, running, these things. But if they don't see the problem, it's more difficult, especially diabetic patients, obesity patients, older patients. When we show them the curve and explain that the curve is not good, the image is not good, it's very educational tool to change in the way, and the patients will accept better our suggestions and treatment. Does anyone have any question?
Let me jump in a minute here,
Right,
Marcos. Yeah, very nice study. Appreciate it a lot. I would mention a couple of things. Those original thermograms you showed, like pre-test, those are not normal. Those hands, whether the one with the cup right or the left, they were not normal. If you look at the fingers, they should be all cool if the person is cool. Now at 23 degrees centigrade, maybe you're sort of in the, in the active zone. I would cool the patients better to see if they cool down. But if you look at the fingers are not normal, are not uniformly cool or warm. They're mixed, and now that's not normal.
Most of patients...
so something else was going on in here.
Let's respond to you. Yes, I saw this, and this patient has already cervical protrusions. He has a numbness, he has maybe arthritis, but nothing of these can change the results. Even though we did this first and then again, and the pattern was the same, because we're talking about sympathetic neurovegetative response, okay? Doesn't matter if he has some other disease in the hands. And also he's a carpenter. He has an amputated finger, because usually these tests are measured on the index finger. We had to change for the fourth finger because these other fingers, they have some amputation in his work. He's a carpenter. He has some amputated end of the fingers, but it was well studied. And before that, 5 months ago, when I had the first exam for this patient, I consult my professor, Dr. Edmar Santos, who is the specialist of this method and validate also this method. And he said, no problem. It's not a case of you're not measuring the hand's disease. You are measuring the systematic reflex sympathetic response. So it doesn't matter. You could do in the hands, you could do in the feet and things like that, okay? So that's very important I like very much you brought here a very important thing.
You did a very important question, Jimmy, because there are some equipments that they measure directly on the finger, especially on the second finger. The other solution similar to thermography, but it's contact, and they don't work so well because on this situation that you told us, because sometimes, for example, some patients have a median nerve entrapment, carpal syndrome, for example, and the test will not work in the second finger. But when you do the infrared image of the hands, you can choose a better place to measure the endothelial test. So we choose the fingers or the places where it's not so involved or normal, that is not so much involved with neurological dysfunction. And by this way, we can choose a better region of interest and to measure the response. But it must be the same in that patient. Most of the time is the second finger, but as we saw in this case, it was necessary to change. Great observation, Jean, of that.
Yeah. One other thing I do want to show you. I don't know whether this is going to show up or not, but this is occlusion. I don't know what this is going to show.
No, I can't see.
Oh well. Anyway, if this is my book, Human Medical Thermography, page 50.
I have it already.
Yeah. If you look at that, if you occlude one finger, its temperature drops precipitously, of course. But all the other fingers are likewise affected, and we're talking about several degrees centigrade. And this phenomenon is a strange phenomenon. Why should occluding one finger affect the temperature of all the others? And you showed that it affected, that occlusion of one arm affected the other arm. This needs to be examined more. There's something neurological happening there that could be diagnostic. Yeah.
It's a systemic response. It's a sympathetic reflex response. So it's easier to understand because of this. That's the way we can use this infrared imaging, for example, to diagnose the complex regional syndrome, the pain complex regional syndrome. It's all about the systemic. It's not local, you know. For example, there is one, I don't know, I don't have this article here now, but I believe you've heard, and Professor Briosco must remember this. If you do every day a compression on your brachial artery for, I think, 10 or 15 minutes, you have this reflex of vasodilation all over your body, and it will help you to have a better outcome in your arteries. They said that it can prevent a lot of cardiovascular disease. I will do this myself. I will test this myself.
But hey, 200 milligrams of pressure, 200 millimeters of mercury pressure in the brachial, it hurts. It's painful.
So
that's the downside.
5 minutes. It's 5 minutes. But no, don't worry, Jean. I will invite you for our. We are doing a training course on 23 November. It will be an all-day course in English, and it's a update training course. So I will invite everyone here and new others, the people that are the members, to stay with us on one-day training course on 23. It would be on a Saturday. It's a very rigid course. You must study a lot. You will have a test on the end. So prepare yourself. It will be immersion. We will have 5 minutes to lunch, but and we'll start at 8 o'clock in the morning and we'll finish at 6 o'clock at afternoon. So prepare yourself. I will send this on the for the next November 23.
Professor,
like,
just a moment, Professor, please. Can you change this data? Because on November 23rd, I will be in another course.
No, we repeat this.
We repeat? Okay. Okay. I'll be with you in the next one. Okay.
I would like to announce that we had a fantastic thermography event and this past weekend in São Paulo at the largest medical pain congress. It's called SINDOR, is the main pain congress in Latin America. And Professors Denise Haddad, that you know, Luciane Balbino, Professor Sidney, and I participated as speakers, training people. We had almost 100 attendees who were truly committed to learning about thermography and pain management. So we are very glad because each month more people are interested on thermography. Many people want to learn more about new approaches as cardiovascular approaches as we showed here. So please, if you're not active members, made your membership at American Academy of Thermology. Follow us on the YouTube. Please share the YouTube videos. We have shorts there. And also send your emails, propose your ideas. And in the next week, we will we invited Dr. Kane. He will talking about hormone and replacement and breast images or some news about that. But if anyone here wants to present, wants to take part, present a topic or something controversial, not need to be a specific class. Here is much more to spread ideas and share comments and trying a little conflict and fighting, acknowledgement fighting here. This is the main of our meeting here. So I would like to thank you so much, everyone here, and because medical minutes is for 6 minutes presentation. So we are very glad with the number of people that are participation with us, and we hope in the next month, on the next semester, a double, triple participation of persons here. And also, Ron, we are also open for listening the veterinaries too. So we are open to all the areas to present their ideas. And I learned a lot with veterinarians, some ideas. So it's possible to change and acknowledgement between the areas. So it's open for everyone here. Thanks so much, everybody. And return safe to your home. Thank you so much.
Thank you so
Thank
much,
you, Marcus.
everyone, to
Thank you very
support
much.
my presentation. Okay.
Thank you, Sidalia.